Hi, good afternoon. Well, the topic is about adrenal gland and its secretions. And at this point, probably most of you having at the lower value of adrenal secretions. So I commend you staying alive and awake for this talk. So let's start with that. The objectives of this is either there is an increased production of adrenal hormone or there is a decreased production of adrenal hormone. What are the causes? What are the treatment and management available for those? And then I'll briefly review the pheochromocytoma, which is at the core of the adrenal gland. Anytime when you talk about pediatrics, I think you have to talk about the fetal status. The adrenal gland is a large gland in the fetus, and it has a predominant zone of fetal portion, and that secretes a DHEA-related hormone, and that is important because sometimes that is what the marker is for the survival of the fetus. The two things that you need to know about the adrenal fetus is that the adrenal function starts at 9 to 10 weeks of age, and that is important. So anytime when you have to do intervention in fetus, you have to do it before then. And the other thing you need to know is that the gonadal differentiation starts after 8. So we'll look into this correlation later on. Let's go for the number one question. The principal hormones of the adrenal cortex include all of the following except renin, aldosterone, DHEA, androstenedione, and cortisol. Key your answer, please. Okay, you got it right, 72%. This is, you had a topic about the kidney. Renin is basically produced in the kidney. All the other hormones are secreted by the adrenal gland. So adrenal gland, the older child, has two main components, the cortex and the medulla, the inner portion. The outer portion consists of 3 regions of the adrenal gland. The outer one, the glomerulosa, which constitute about 15% of the adrenal gland. And then the middle portion, zona fasciculata, which is almost 75% of the cortex and secretes cortisol and corticosteroid. And then the 10% zona reticularis produces sex steroid, DHEA, and androstenedione. These are the two principal androgens secreted by the adrenal gland. And then the core of the adrenal gland, which constitutes about 10%, produces catecholamines. And we will talk about briefly about pheochromocytoma, and its role will become evident at that time. The adrenal cortex function is regulated by ACTH. So ACTH stimulates the production of the cortisol. ACTH also activates the zona reticularis to produce, to some extent, androgen. It has a very minimal activity on the aldosterone pathway. Aldosterone pathway is mainly regulated by the renin-angiotensin system. The ACTH in turn is activated by CRH, and CRH you know can be affected by the stress, by the infection, by the fever. So that's why when you have a state of stress, you have increased production of these adrenal hormones. Let's talk about lower production of the adrenal hormone that leads to adrenal insufficiency. You can classify adrenal insufficiency in 3 different types. Primary adrenal insufficiency, where the defect is in the adrenal gland itself, and the adrenal gland is not producing enough cortisol. And one thing about the endocrine tissues and organs is that you got to have almost 90% loss of the gland before you start manifesting any deficiency of any of those endocrine hormones. So you got to be more than 90% of the adrenal tissue being lost before you start manifesting adrenal insufficiency. Then you have the secondary adrenal insufficiency where the defect is in the pituitary, the ACTH is not being produced, or you have a hypothalamic one where it is suppressed from exogenous that leads to tertiary adrenal insufficiency. So let's go for the question number 2. Causes of primary adrenal failure include all of the following, except infection, genetic defect, autoimmune, hemorrhage, and hypopituitarism. You can key in the answer. We're talking about primary adrenal failure, so the one which is not correct. Yeah, got it. So that's the hypopituitarism is a cause of the secondary adrenal insufficiency rather than the primary. Some of the causes of the primary adrenal failure is the number one cause in this country and developed countries, autoimmune. So there are two types of it, APS1 and APS2. APS1 happens in the early life, in childhood, less than 10 years usually, and APS2 is usually happens after 10 years of age. APS is characterized by the mucocutaneous symptoms. The mnemonic for that is HAM. It is associated with hypoparathyroidism, adrenal insufficiency, and mucocutaneous issues, fungal infection. And the second sometimes we see is bilateral hemorrhage, especially after delivery, difficult delivery. Infection is one of the worldwide most common cause of adrenal insufficiency, particularly TB. Sometimes overwhelming sepsis can knock out the adrenal function. You can have infiltrative disorders like adrenoleukodystrophy. This is important to know that if this is an X-linked transmission, so if you see adrenal insufficiency in a male, you got to exclude adrenoleukodystrophy. That could be the cause of the adrenal insufficiency. The other thing is some transcription factors like DAX1 and steroidogenic factor 1. These are important for the development of the important for the development of the adrenal gland. So one needs to be cognizant of these factors. The most common one that you will be expected to know about is the adrenal enzyme defect in the biosynthesis of that adrenal pathway. That's the dreaded pathway for the resident. Then don't forget the drugs, the medications can cause adrenal insufficiency, ketoconazole and mitotane and those kind of things. In secondary, the defect is in the basically pituitary, and that's what causes the problem. So any lesion in the pituitary, you just heard from Dr. Narasimha about the pituitary and hypothalamic area, so any lesion in that area will lead to secondary adrenal insufficiency. And then you can have a tertiary defect in the adrenal secretion at the level of CRH at the hypothalamic region when you are giving exogenous source of steroid, the glucocorticoid. And sometimes we don't see that commonly, but there are certain infiltrative disease when you have a defect in the upper pathways of the cholesterol metabolism, where the cholesterol cannot be further broken down. Then you have accumulation of the byproducts of that. Wolman's disease is one of those. It is a disease becoming of interest because now we have a treatment available, and is an enzyme defect, lysosomal acid lipase, and now we have a recombinant way of making that enzyme and treating these children. Smith-Lemli-Opitz syndrome is another one where you have a defect in the higher level of the cholesterol. And obviously the congenital adrenal hyperplasia, where you have a defect in the biosynthetic defect of the adrenal gland, and that basic defect in that condition is that you have a decreased production of cortisol. And decreased production of cortisol leads to increased ACTH. So ACTH then revs up the pathway, and then precursor to the defect in the adrenal pathway, because the enzyme is defective. So precursor to that one, you have an accumulation of that hormone, and distal to that, you have a less of that hormone. So low cortisol then leads to increased ACTH and leads to hyperplasia. So it's kind of a paradox that you have a condition where you have an insufficiency, yet the gland is huge, it's enlarged. You have hyperplastic gland. It's because of the increased ACTH secretion. 21-hydroxylase deficiency, congenital adrenal hyperplasia, is associated with all of the following, except genital ambiguity, growth failure, infertility, irregular menses, and acne. One of that condition is not correct. Which one is that? Okay, there's a mixture over here. Actually, the correct answer is B. Patients who have congenital adrenal hyperplasia, and if not properly treated, they end up presenting as a tall stature. They grow fast. So if you have an excess production of cortisol, then you end up having growth failure. So growth failure is the odd one out. You can have a genital ambiguity, obviously, in a female patient. Let's get to that pathway. That may help us. Okay, so the defect on 21-hydroxylase is a defect in this enzyme, 21-hydroxylase. This is the most common form of congenital adrenal hyperplasia. So when precursor to this hormone is 17-hydroxyprogesterone, distal to this blockage is the cortisol, so you have a low production of cortisol. So by biofeed mechanism that increases the ACTH and revs this pathway. So you have accumulation of 17-hydroxyprogesterone that gets diverted into androstenedione down, and that's the androgen that peripherally gets converted into testosterone. And if you can imagine, if you have a patient who is a genotypically female, increased production of testosterone will lead to ambiguity of the genitalia. Also, if you have a complete absence or lack of this enzyme, you have a defect in the production of this pathway, aldosterone pathway, and you get hyponatremia and hypotension. So that's the effect of this 21-hydroxylase deficiency. There are usually two types of congenital adrenal hyperplasia. One is the classical that we described, that is found in early life, early onset, and there is a late one, non-classical. So if you have an enzyme, remember, we're talking about enzyme 21-hydroxylase. So if the activity of that enzyme is less than 1, basically no activity, you end up having a salt-losing type of congenital adrenal hyperplasia. So no enzyme activity will lead to salt wasting form. If you have some activity, 1% to 2% of the enzyme, you end up having only simple virilizing. Your aldosterone pathway is spared, basically. So you don't have this pathway. The only pathway defective is this one. As a result, you have increased production of this, and that leads to increased androgen formation, and hence the ambiguity of the genitalia. In non-classical, or that happens in the late onset, later in the childhood, there is more than 10 to 20% enzyme activity. And hence, they do not present with abnormalities in the newborn period, and usually manifest as premature adrenarche or pubarche, as Dr. Narasimha has mentioned, and can present with hirsutism and severe acne and irregular menses, and sometimes it can cause infertility in male, and I will come to that. So this is a genotype of 46XX, and you can see it's so much androgenized that they look like a male phallus, small phallus there, and pigmented scrotum there. The thing to know about the congenital adrenal hyperplasia is that parents are not affected. It's only the siblings that are affected because of the recessive, autosomal recessive defect there. And ratio is male to female is 1:1. And presentation of 21 hydroxylase in infant, newborn, basically it can present with adrenal crisis. And before the institution of the newborn screening, most of them, they presented with adrenal crisis. 2/3 of it presents with complete loss of the enzyme function that leads to adrenal insufficiency. You have a lower production of aldosterone pathway. You have a decreased production of cortisol. Lower aldosterone leads to volume depletion, hyponatremia, hyperkalemia, and cortisol deficiency causes impairment of the catecholamine functions leading to poor cardiac function. Combination of these two is lethal. They end up having a severe dehydration and shock. So that's the mechanism whereby you end up having a CAH 21 hydroxylase deficiency presenting as adrenal crisis. In males is a different story. In males, you already have excess production of testosterone, so little bit more addition of testosterone by adrenal gland is not going to cause too much of androgen. So it's just like putting a salt into a seawater. You're not going to make it saltier. So that is, so ambiguous genitalia is not. The only thing you may find is slightly increased pigmentation or slight increased phallus size, but it all is on the eye of the beholder. And then in children, older children, it can present at tall child because the androgen, if it's missed, especially if it's a virilizing form and is missed, they can present as a premature adrenarche with increased growth velocity leading to tall child. So these are classical tall child but short adult. And then in males, in adolescents and in adult, the testicular, remember there is a remnant of adrenal rest tissue in the testis. So when it is poorly controlled, the adrenal rest mass starts getting increased because of the increased ACTH secretion. That can lead to infertility. So your gonadal function is suppressed and also lead to oligospermia in infertility. Why do we have this? One of the common causes of autosomal recessive defect, and one of the reasons why we have increased 21 hydroxylase defect is because of we have two genes. One is the pseudo gene, the dummy gene is not active, and then you have in tandem active gene which is there, and they are very homologous, more than 90% homologous. So sometimes you can have a crossing over, or you have a misalignment, and you can see they can they can be mutated, and the enzyme activity could be impaired. We have newborn screening, and that really has identified this congenital adrenal hyperplasia in a very early form. Before the era of newborn screening, the average age when we used to have this was about 2 to 3 weeks age. And the newborn screening has really reduced these average, even with the delay in the lab, about 9 days. Many European programs do the test after 48 hours. Also in US, which strive to do towards 48 hours after birth. If it's done within 48 hours, you may get a false value, and it will be advisable to repeat it in 2 weeks. If before 24 hours, if the value is done, if the lab is done within a day, then I think it's better to repeat and do it at 48 hours. When you get the newborn screening, a real bona fide salt-losing congenital adrenal hyperplasia, the value is usually over 10,000. It's not 500 or 600. Most of those 500, 600 or slightly elevated, they are either late onset or just a heterozygote form. And 17-hydroxyprogesterone over 1,000 is usually the non-classical type, or maybe even the late onset type. So a classical one with salt losing, the value is usually greater than 10,000. And remember, the cutoff values are based on the gestational age. This is not part of the adrenal, but I just wanted to highlight it that it's important to remember the number 8. Before 8 weeks of gestation, all of us in this room were having the same sex. We were almost the same gender. It was after 8 weeks that the development of the testis and its secretion leads us to the development of either the male external genitalia or kept it as a female. So the gender basically is dependent on the testicular development. And before 8 weeks, we are all the same. After 8 to 12 weeks, androgen exposure can have a significant effect in virilization of the external genitalia. So if you have a female and you have exposure of the androgen, be it from the adrenal gland function, it starts functioning around 9 weeks, then you may have a significant ambiguity of the genitalia. And then if the androgen exposure is after 12 weeks, you have a minimal abnormality in the genitalia. So in a genotype 46XX, you may end up having slight clitoromegaly. And this leads to the evolution of the treatment, prenatal treatment of congenital adrenal hyperplasia in a center where you have a perinatal department and prenatal department. There is a way of at least reducing the surgery that is involved with the genital ambiguity. So the purpose of prenatal congenital adrenal hyperplasia treatment is to reduce the surgery, not to reduce the cortex, but reduce the external, because that is a very difficult surgery, and it has lots of, especially in this era, lots of connotation about gender. So that is the purpose of this treatment. And we use a glucocorticoid, which is dexamethasone. And dexamethasone is the one that crosses placenta. If you use prednisone or hydrocortisone, that will get denatured by the sulfotransferase, the DHES sulfate. It just dissociates it. So it doesn't cross it. So you have to use a dexamethasone that crosses the brain. And treatment is before 9 weeks gestation. Remember, the adrenal production starts at 9 weeks. So if any treatment that is needed, it got to be before 9 weeks. And in the olden days, we used to do the CVS sampling, and that was usually done at 10 to 12 weeks. So it was too late before we could identify which one is susceptible. So basically, as soon as the mother gets pregnant and there's a history of congenital adrenal hyperplasia in the sibling or suspicious in the family, then you start the treatment. And once it is later confirmed that this patient is a male, then you can discontinue the treatment. Or if the fetus is unaffected, then you discontinue it. These days we have a modern technology. We can basically identify the fetal cell even in the maternal blood. So their newer technology has come up where you can identify those just from the mother's blood. The other form of congenital adrenal hyperplasia that you need to know about is the 11-hydroxylase defect. So this is the one where you have a defect further down, is a defect in 11-hydroxylase defect. So if you have a defect here, the precursor of that hormone is 11-deoxycortisol. So that is increased. Also, the precursor of the 11-hydroxylase is DOAC. So you have a significant amount of DOAC and 11-deoxycortisol. 11-deoxycortisol then goes accumulated in 17-hydroxyprogesterone and then goes through this pathway, androstenedione, and then converted into testosterone. So if you have a 46XX genotype, that patient when exposed to testosterone will lead to ambiguity of the genitalia. However, here, what happens is DOAC is a significant mineralocorticoid. So you have an increased production of DOAC that functions like aldosterone. So this DOAC leads to hypertension. So this is the CAH where you don't have adrenal crisis, but you have a hypertension. The best way to mnemonic is 11-hydroxylase. 11 looks like two arms of the H. So hypertension for H, 11-hydroxylase for hypertension. Then the third one, you have a defect further up. And here you have a defect in 3-beta HSD. And as a result, you don't have any testosterone androgen production, you don't have cortisol production, and you don't have any mineralocorticoid production. So you end up having salt loss, you end up having glucocorticoid deficiency, and you end up having androgen deficiency. But this happens in the male, so you don't produce the testosterone. Male will be born with ambiguity of the genitalia. However, the story is a little bit different in female genotype, where you have accumulation of DHEA. So DHEA can be accumulated, and when you have a humongous amount of DHEA, they act as a mild virilization. And that mild virilization may be enough to cause ambiguity in the genitalia. So this is a condition where you have an ambiguity of the genitalia in both gender, both karyotype, XX and XY. So that's one of the important distinguishing feature about this one. So to summarize, the 21-hydroxylase, you have salt loss where the enzyme activity is less than 1. You have a simple virilization if you have a 1 to 2%. And when you have 10% or more, you have a non-classical that happens later. And 11-hydroxylase characterized by hypertension, hypokalemia, but no salt wasting. And 3-beta HSD, you have ambiguity of the genitalia in both gender, and then you also have a salt loss. Your pediatrics board expects you to know what are the causes of virilization in a female. So I put that in a perspective. So you have a 21 hydroxylase, 11 hydroxylase, 3 beta HSD. And some other causes of virilization in the female could be from the maternal androgen exposure. It could be in the form of tumor, or it could be androgenic drugs. This is a little bit busy slide, but I want you to understand the testis has two components. It produces it has a Leydig cells which produces testosterone. Testosterone then acts through the receptor to promote development of the male characteristic feature and external genitalia. So if you have a defect in this pathway, in the male individual, this is affected. Also, if you have a testis and the Sertoli cell is there, you eliminate the Mullerian structure. You basically eliminate the female structure. And the reason why I'm showing you this is because in the board exam, every 4 or 5 years cycle, they ask you a question about somehow related to complete androgen insensitivity. And here you have a patient who have basically a 46XY, and this presents usually with blind vaginal pouch. And the Wolffian ducts, because the testosterone receptor is not functioning, so they don't have the action of they have rudimentary Wolffian ducts, and they don't have any female structure because the testes produce the AMH, anti-Mullerian hormone, and that wiped out the female internal genitalia, so they don't have uterus. And they are basically hairless women. Some of these 46XY hairless women have gone to become a beauty. They have, become a beauty pageant, and basically defeated the 46XX because there was no androgen at all. So these are good-looking people. They don't have this nasty acne that comes from the testosterone. The hormone profile they can ask you about is they have increased elevation of the LH and increased testosterone. FSH may be slightly elevated because LH is the one Leydig cell that produces the testosterone. And the defect is basically the resistant to the androgen receptor. Let's go into this question. Patients with secondary adrenal insufficiency may have all. So weakness and fatigue, hypoglycemia, hyponatremia, hyperkalemia, and hypotension. So which is the one that is not present in secondary adrenal insufficiency? Well, you have two things, hypoglycemia and hyperkalemia, and hypotension also. Actually, the correct answer is hyperkalemia because the potassium is affected by the aldosterone pathway, renin-angiotensin system. And in primary adrenal insufficiency, you have a defect in the aldosterone pathway. But in secondary, the defect is only in the pituitary, and you have only glucocorticoid defect. Aldosterone pathway is intact, so you don't have hyperkalemia. So it's characterized by glucocorticoid and androgen. You remember one of the first earlier slide, the ACTH affects the cortisol and the androgen, but it spares the mirocorticoid. So may have hyponatremia, but normal serum potassium. This is to distinguish between primary adrenal insufficiency and secondary. And the unique thing about primary adrenal is that they have a craving for salt because they have a defect in the adrenal, in the aldosterone pathway. And they have increased pigmentation because the ACTH is elevated, so they have pigmentation. In secondary, you don't have pigmentation. And in primary, obviously, you have a decreased aldosterone, and this is not present there. but both of them have glucocorticoid deficiency. So you want to investigate for adrenal workup. These are all listed in your handout, so you have that one. Sometimes if the basal value doesn't make sense, we do the stimulation studies, and we use the standard form, 250 microgram ACTH, and we measure the cortisol level at 60 minutes. It got to be about 18 to 20. This is also in your syllabus, what the maintenance dose is. You're expected to know different forms of glucocorticoid and what their potencies is. One of the things I would like to draw is the fludrocortisone has the highest amount of mirocorticoid activity, and dexamethasone has the least activity of mirocorticoid, but it has a most potent glucocorticoid activity here. A stress dose, you're expected to how to give the stress dose. Basically, at the time of stress, your ACTH goes up, and ACTH is supposed to stimulate the cortisol. If cortisol is not there, then you may need to double or triple the dose. No increase if it's a minor stress, less than 100 or above fever, double the dose. If it's more than 100, to triple the dose. During surgery, the most important thing is the call to the OR, give about 80 to 100 milligram per meter square hydrocortisone. And post-surgery, you also manage about 100 milligram per meter square every 6 hours. You got to know adrenal crisis, how to manage it, how to treat it, and make sure that you're giving the D5 and normal saline fluid, and you're also giving IV hydrocortisone stress dose based on the age. Your board expects you to understand the symptoms of the glucocorticoid withdrawal, and basically if you put someone on high dose of glucocorticoid, you need to withdraw the steroid very gingerly. If you do rapidly, you end up having glucocorticoid withdrawal syndrome, and basically they are just like a secondary adrenal insufficiency. They don't have any salt loss because the glomerular function is fine. Typically what I do, and everyone does differently, I reduce 25% every week for the next couple of weeks. Let's go into the excess production of the adrenal gland. The clinical features of Cushing syndrome include all of the following, except hypertension, obesity and striae, alopecia, growth failure, and precocious body hair distribution. So one of the features are not present in Cushing syndrome. Which one is that? Very good, you got it. It presents with hirsutism, increased body hair. So alopecia is not a typical feature of the Cushing syndrome. This is the typical picture. And one of the most important thing with Dr. Narasimha included about growth failure is that these children, their growth velocity is decreased in Cushing's. And in exogenous obese patient, the growth velocity is increased. So they are tall. So in order to distinguish Cushing syndrome from the overnutrition, is you look at the growth rate. If the patient is tall, it's most likely this patient has overnutrition problem. And if patient is short and overweight, then you start considering Cushing syndrome. These are some of the features of the Cushing syndrome. And the yellow one, the highlighted one, is very specific to the pediatrics. And this was the compilation made by the NIH. They are the people who see lots of Cushing syndrome. One of the most important things you need to know is the bone age is delayed in pediatrics. If you see a Cushing syndrome, it's extremely rare. And most of the common cause of Cushing syndrome is exogenous Cushing syndrome because we are giving lots of medications, hypotensive, glucocorticoid. So endogenous production, where you have an increased production of cortisol from the adrenal gland, is rare. So you have to take into that consideration. Any Cushing syndrome less than 7-year-old is most likely the defect is in the adrenal gland itself. Adrenal adenoma will be the most likely cause. If you see a Cushing's features in a teenager or older children, most likely the Cushing's is a pituitary dependent and the defects in the pituitary region. So that's why age is a very important factor in distinguishing whether the location of the Cushing is in the adrenal gland or is it in the pituitary. By definition, a lesion in the pituitary is called Cushing's disease. And you have a very characteristic in pediatrics called nodular adrenal hyperplasia, and that can cause cyclical Cushing syndrome. So they can have an episodic secretion of the cortisol and can present with those kind of features. This is just to summarize that Cushing's disease refers to pituitary. So how do you evaluate Cushing syndrome? Basically, don't measure random cortisol. Most of the time we get referral from the physician is that they have measured the cortisol level and that is high. The cortisol level in Cushing syndrome doesn't. If you got to measure the cortisol level, measure it much later in the evening, 5 or 6. But these days we usually don't advocate because any kind of stress will lead to increased production of cortisol and you can get a falsely elevated value in the evening. So there are 3 ways of diagnosing Cushing syndrome. One is getting a midnight salivary cortisol. Remember, the cortisol has a diurnal variation, so at midnight, the cortisol is the least being produced. It should be almost not there. So if you measure the salivary cortisol, you give them something to spit in the cup, and you have a cotton swab. They just put in the mouth and chew it, and all the saliva gets there, and then you put the cotton into the cup, and then send it to the lab. The other one is, if it's an older one, you can measure the 24-hour urinary free cortisol collection. So urinary free cortisol is another way of analyzing excess production of. And the third easiest one is give them a dexamethasone around 11 p.m. or so in the midnight and measure the cortisol level first thing in the morning around 8 o'clock. So if someone has a Cushing syndrome, the cortisol in the morning will not be suppressed. It will still be elevated. So elevation of the cortisol following an overnight dexamethasone will be suggestive of cortisol. Typically, you end up getting at least 2 samples, different way of measuring cortisol to make sure that you're not dealing with Cushing syndrome, because there are lots of false positivity with this, especially overnight dexamethasone and sometimes urinary cortisol collection. Once you have established hormonally, then you go ahead and do the imaging study. Don't go and do the image first and then start looking for all those things. That should be done after you have done that, investigated biochemically. This is just to let you know that adrenal tumors can produce some of the other hormones as well. Let's look into the core of the adrenal gland. So is extremely rare. 90% of the time when you have increased production of the catecholamines that are usually benign, 10% may be malignant. And if you happen to diagnose pheochromocytoma, you got to establish that there is no syndrome going on, because most of the pheochromocytoma that you present in children, they may be associated with syndromes. So the board expects you to know some of the syndrome that may be associated with pheochromocytoma. And the best way to diagnose this one is measure the free methanephrine and normethanephrine. You'll be able to exclude more than 90% by measuring methanephrine and normethanephrine. If they are elevated around 4 times the upper value, then most likely it's pheochromocytoma in the given history of hypertension, diaphoresis, palpitations. Okay. Pheochromocytoma is associated with all of the following except neurofibromatosis, Van Hippel-Landau syndrome, MEN1, MEN2A, MEN2B. So of all the syndrome, which one is not the correct one? Very good, you got it. MEN1 is the one not associated with pheochromocytoma. The rest of them are associated with if you're wondering what Van Hippel-Landau syndrome is, this is a mnemonic for Van Hippel-Landau. It's basically a visual defect. You have a nephron cyst and cerebellar cyst. And this is the main MEN1, MEN2A, and 2B. So those are the associated findings. Okay, good luck.